Thank you for joining for this educational event that's put on by Tactile Medical. The topic tonight will be CVI, patient care in the era of telemedicine. Just a few things. You can submit Q&A questions throughout the event. Some of these we'll pick up as the event is going on and answer them. Some of them we'll get at the end of the session. Also, whoever's not able to attend or gets off the meeting, or if they want to re-listen to this event later on, it'll be available on the Tactile website at tactilemedical.com/learning. So our speaker today is going to be Nick Morrissey from Columbia, and we'll start off with some poll questions here before we get going. Sorry. How much of your practice treating venous disease? You can see about over 34% are treating over 75%. Okay. And then kind of split between the other groups. Here's your results. And second question. How has COVID-19 impacted your practice? I don't know about yours, Nick.
The venous practice is largely on hold right now.
Yeah. Same here. I mean,
and everything is actually, except for bypasses for gangrene and symptomatic aneurysms.
Yeah. I mean, obviously, both of us being in New York, being affected the most. So severe. Over half the people on this call, severe. 70% either closed practice or severe impact. Yep, new world we're living in. Let's see, one more question and then we'll start off. Okay, here we go. How many of you are using telemedicine? It's pretty amazing how an institution, probably to launch telemedicine would have taken over a year on normal times. Isn't it amazing how things can happen in a week?
So at our place, we had gone live with Epic across all campuses on February 1st, because we were not an Epic shop before. So we went live on February 1st, and then a month later we had COVID. So it was quite a baptism, but thank goodness, because that's made it easier for us to do telemed.
So still about 37% are not using telemedicine.
Yeah.
Okay, and actually there was one more question that we had here. If you're using telemedicine for venous patients, what stages are you using it for? And you can pick more than one here. How about you, Nick? What are you?
You know, for established patients with wounds that we've been managing, venous stasis wounds that are even pretty severe, if they have good home support, I've been doing weekly visits with them and they've been doing well.
Yeah.
So all of them.
I mean, the only ones we bring in is if, you know, they need some type of Uniboot or anything and they can't do the dressing changes on their own.
Right.
All right, and so pretty much across the board, interesting, C3 is the hardest one, but about the same between everything. All right, so so Nick, you want to talk a little bit about this patient that we're going to show?
So we decided to have a demonstration of a televisit. So this is a patient of mine that originally was treated for an aortic aneurysm about 4 years ago. And, and during his post-op evaluations, he did mention the fact that he had this severe swelling after some orthopedic surgery. So while I continue to monitor him after his aneurysm repair, we've now taken on treating him aggressively for his lymphedema and venous insufficiency. So we performed a telehealth visit to try to demonstrate how we manage him. Since with the COVID crisis, we're not having many people come directly in the office.
Okay. So this is a pretty entertaining guy.
All right, Frank, how are you feeling today?
I feel pretty well. I feel pretty good.
You're staying healthy with all the virus stuff that's going on? You haven't had any cough or anything like that?
No cough, and I've been a good student. I'm at home. Only time I go out is I try to go walk a little bit on a track, and that's about the only exercise I get at the present time, but it's enough at this time.
Good. So we had met before and talked about your leg swelling, which you developed after some Achilles surgery. You had ultrasounds back then, which didn't show any blood clots, but you had seen some other vascular doctors who thought about maybe doing a procedure, and then you came to me for another opinion. Is that correct?
That's correct.
Yeah. What did we do the first time we met? I think we went over your history, we examined you in the office, and I believe we started you on some compression stockings. Is that right?
That's correct. And also, you gave me a Doppler test, and that's when we had a little bit more investigation about my legs.
Yeah. So you tell me about the feeling that you had when you would walk before we met, before we started the compression stockings. How did your legs feel when you walked?
Well, my legs felt very heavy, and it was quite disheartening because I couldn't walk the way I wanted. And I am 82 years old at this point in my life, and I figured that I was slowing down a lot, but I tried the best to exert myself and be half decent with regards to exercise.
Yeah, well, you always have been very active, and you don't look 82, so that's a very good sign. You look much younger than that. And we really wanted to focus on getting you back to the activity level that you were used to. So we talked about, your heart is pretty strong. You don't have a history of heart failure. That's correct?
Right.
And your kidneys work well.
Right.
We went over your medicines last time, and you don't have any medications on your list that I saw that would cause the swelling. We did go over your Doppler study, which, although there were no clots, there was as you had mentioned, the valve issue in your vein, which another doctor had identified. I think based on that, we knew that you had venous insufficiency, which then led to this lymphedema that you're dealing with, which is the swelling and the heaviness. Is that how you remember our first visit?
Yes, that's exactly right.
Yeah. All right, Frank.
Because I couldn't walk the way I wanted, and I am
study, which although there were no clots, there was as you had mentioned, the valve issue in your vein, which another doctor had identified. I think based on that, we knew that you had venous insufficiency, which then led to this lymphedema that you're dealing with, which is the swelling and the heaviness. Is that how you remember our first visit?
Yes, that's exactly right.
Yeah. Let me ask you about the discomfort that you have when you're walking again. Please describe it for me again, the sort of the heaviness. Is it like carrying weights around on your legs? Is that how you described it?
That's exactly right. It feels like I put maybe 10 pound weight on each leg. And the legs really bother me mostly, or I should say, the heaviness is more prevalent when I'm sitting. I can feel my legs feeling very heavy. And I tried to elevate them when I was going to sleep, and it did help somewhat. But they still hurt and heavy when I sit.
Okay. Well, that's good to know. Now, we did start the compression stockings, and you have been very good about wearing them on a daily basis. You have had some improvement with that?
Yes, some improvement. Correct.
Okay. Is it possible we can have a look at your legs with your phone? You can have a look and show me how you're looking today?
Okay, I'll show you that. Right now, there's my foot, and I'm going up to my calf.
Yeah, but maybe
sides, and I'm up to my thigh.
Okay, let's go down to the ankle again. Pull the phone away a little bit. Yeah, there you go. Yeah, so you can see some of that swelling down there at the ankle.
Yes.
Yeah. Okay. And you can see even a little indentation on the foot from where your shoe was, huh?
Yeah.
Yeah. Okay. That's good to see it.
I have the same problem with my right leg.
Yeah, I can see that. Yeah, and you got some of that discoloration there you see on the calf, which we talked about before, which is because of the valves and the veins not working for a long time. Okay, let's go back to face-to-face.
Okay.
So, as I mentioned before, when we first met, is that the most important thing for us to make you better is that you and I work as a team and that you're committed. And you've demonstrated that by being so compliant with your compression stockings at this point. I think that there's a possibility we can help you even more by perhaps getting you a machine that can help eliminate more of that fluid out of your legs, which would make the heaviness be even less, which I think would help with your walking even more and with your comfort. What do you think about that?
That would be most welcome. Anything that would help me would be more than welcome.
Yeah, because you were when you were younger, you were a professional baseball player, right? You got drafted, right?
Yes, by the Cleveland Indians. Yes.
Yeah. So you have an athletic background,
right?
Which is, I guess, why someone who's 82 stays in such good shape.
Well, yeah. Considering some of the things that I have now, I actually look at. Actually, to be honest with you, dream on some of the games that I pitched. But I got injured very early in my career. I had bone chips in my elbow. And at that time, they didn't have orthoscopic surgery. So an operation was performed, but that was the end of my career.
Yeah.
Because they cut the muscles and everything on that.
Well,
that was the end of Frank.
Well, it was the end of the baseball playing Frank, but the athletic, vigorous, active father, grandfather, and current Frank is still very strong. So we want to make you even more comfortable. So we're going to look into getting that machine for you to get the swelling down even more. And I'll be in touch once we get approval and talk about getting it to you. And then we'll follow up soon after that.
You can't come fast enough. I'm looking forward to it.
All right, good. Well, we'll do that, okay?
Very good. I appreciate it.
Stay healthy, and we'll talk very soon, okay?
Very good. I'm waiting.
All right. So, Nick, you want to add anything to this?
I've had several visits like that with other patients since COVID crisis with televisits. And although this was an established patient, I think when we go through some of the algorithms, we can see that even for a new patient, we can, with some degree of certainty and safety, get them through a new patient visit as well.
Yeah. Now, one of the questions that popped up was, what kind of system do you use to do these televisits?
So it's interesting. We are on Epic, and Epic has a good system for doing televisits. One of the things that's come down from EMS during the COVID crisis is that you can actually use other platforms, such as Zoom, or actually Zoom is less attractive, but Google and FaceTime. So if you don't have a system in place to do that during the current crisis, they will allow that. I mean, originally, I didn't think they would because of the PHI and whatnot, but they are allowing it.
Yeah. We have at our institution, we're using Microsoft Office Teams, and it integrates with our network and, with our system, and they can make the visits. It sends it to your office calendar, and it pops up. So it's pretty easy.
Yeah.
One thing we did is actually, this is up on the slide here, a template of a note that we've created so that it makes it easy to just, as you're doing the visit, you can be just typing this in. So some of the key things that are required for telemedicine is indicating the location of the patient, the location of the provider, the total time spent, the severity of the visit, and also verbal, documentation that the visit was done using audio and video, as well as documentation that consent was obtained by the patient. So this is kind of on the template that we have. We've included all the requirements, so you don't have to redo it every time, as well as some of the codes. So coding wise, it depends really on the amount of time, and it's different based on if it's a new visit or an established visit. Now, quick question for everybody. So what's the thought as far as RVU reimbursement of telemedicine code versus E&M code? Is it the same, lower, higher? What do you guys think? So it's actually, it is the same as a regular E&M visit, at least for the time being. Now I'm sure once COVID-19 is over, there's going to be a shift maybe to lower RVU or reimbursement. I'm not sure. What do you think?
I think they may keep it the same, but I think what's interesting is I think the payers may like this because if you think about it, every visit has a timestamp. And, I think that they may end up paying, even though the codes and the RVUs are the same, the payout may be less.
Yeah.
They'll say, well, you only spend 10 minutes on the phone. So,
well, what's your experience with patients? I mean, how easy do you see them accepting to do this versus wanting to come in, versus, ease of use for them?
We've had a lot of good buy-in, and I find that some of the older patients, they'll often get a grandchild or a child to help them through it, and they actually navigate it pretty well. So the older, frail ones, they do like the opportunity to do this, and if they're established patients, they really do like to see their doctors. It's kind of a nice interaction for the time being.
Yeah. I just put this is what we have in our practice just for providers to make it easy, what the codes are, what the requirements are. So it's based on medical decision making. So it's either low, moderate, or severe, or the time that you spend. And the difference between, you can see the RVU difference between a regular phone call and one of a new patient visit. So 3 RVUs versus the highest level you would get for a phone call would be 1.1. So there's definitely an advantage of doing this from a reimbursement perspective. And I think also you do get a better rapport with the patient by, visually looking at them. Nick, you want to go through some of this as far as how you evaluate these patients with health?
Yeah, obviously we go through the algorithm of, especially if it's, occasionally you'll get actually not more than occasionally, new patients who call to have a televisit for swelling, and you really want to drill down whether they're acute or chronic. You also want to nail down whether unilateral, bilateral. Obviously with the acute situations, you have to figure out a way to rule out DVT if you have a clinical suspicion of that. We have found that since we're right in Manhattan, and it's really tough to get people to our lab, a lot of our patients in the outer suburbs or in the outer boroughs can go to an ultrasound lab nearby and rule out a DVT, or they may have had one done by their doctor beforehand. So a lot of times we can get that information before the visit. And then, we sort of break it down, acute versus chronic and uni versus bilateral. Yeah, and we think about these types of processes, especially with the more recent onset. DVT obviously has to be top on our list. I always ask about recent activity. I've seen a couple of people who clearly had muscle tears, but then went on to develop DVT. So you can have both in the same patient. Superficial thrombosis, other things that are less common, like masses or tumors. But you got to keep in mind the muscle strains, which can lead to similar symptoms. In the chronic situations, a lot of times the symptoms that they describe will sort of give you an idea about some of these things, and they may carry a diagnosis already before they see you. I think we would all probably agree that a lot of the folks that come to us have already had a diagnosis and may have had previous not only studies but procedures done, which may give a clue to what they're dealing with. There's some less common things like you always have to rule out the heart failure and the renal failure. I think about things like hepatic disease as well, with ascites and sometimes compression of the IVC. Any sort of outlying types of things you kind of want to keep in the back of your head, especially since you can't examine them hands-on in this situation. You want to get a lot out of the history if you possibly can.
And the thing is, a lot of this, again, you can get just by talking to the patient. I mean, and getting a good history from the ultrasound is a key part in whether, the decision at the time that you see them or you talk to them, if they need an ultrasound or not, you can always schedule that up. Sometimes what we do is we'll have them, if we suspect something acutely and we want to make sure they don't have a DVT, we'll have them get their ultrasound first. And then, like you said, have them come back and do a televisit with them over the phone after we get the results. But it's interestingly, leg swelling, you can see here there's a pretty extensive and long list of potential causes. And that's one of the reasons I think we see a good number of patients, whether it's with superficial interventions or deep interventions, a good number of these patients don't improve after intervention. You look at the literature, 50% of them, when you look at swelling itself as an indication, doesn't improve after intervention. And that's because, unless you do a very thorough evaluation, you're going to miss things that don't get better by stenting them or ablating them. So I think the history and telemedicine actually may give you that opportunity to do a more thorough evaluation of these patients. I find it very useful to be doing these, after hours or in the middle of the day when I'm not doing anything, to just bang out 5 or 6 of these. How many do you usually do a week?
We're ramping it up. I think I'd probably do about 10 a week.
Is it?
I'd encourage people to do more. But as you get more facile with it, it becomes easier.
Definitely. Let's see. Got another question here. All right. So what's the most common cause of lower extremity lymphedema? Cancer, primary, CVI, or surgery? All right. So, well, I think the notion of chronic venous insufficiency being one of the leading causes, if not the leading cause, is getting out there. And actually, this is a paper that recently Steve Dean published showing that over 40% of patients have CVI as an underlying cause of lymphedema, whereas in the past, cancer was thought to be the primary cause. So this is just showing basically, when you have a patient and you figure out is it acute or chronic, if it's acute and it's unilateral or even sometimes bilateral, you want to rule out conditions that require in-person care or in-person evaluation with an ultrasound. You want to run through this, Nick, a little bit?
Yeah, I mean, I think we sort of think about things in the chronic edema situation. You always look for those primary causes which need treatment or may benefit from treatment of the primary problems, such as cardiac disease, kidney disease, liver disease, malnutrition with low albumin. OSA and obesity kind of run together, but with all that pressure intracavitary on the large veins. It's funny, a lot of those folks come to you and having had a long history of pulmonary disease, and all of a sudden one day they get a lot of swelling, but built up over time. Those types of things that can be treated primarily. And if you treat them and they don't get better, then you move to the next stage, which of course, most of these patients anyway will get imaging, and venous duplex of the extremities and the iliac and IVC is very important for all of these folks. Look for fluid in the subcutaneous tissues and whatnot. So we then stage them according to their venous disease. And if they're greater than C3, then the stage of lymphedema, that's their sort of their phlebolymphedema stage. Then you can sort of diagnose primary, secondary, and secondary with different causes and other causes of the edema, and then take you down the pathway towards treatment. So it's a lot of stuff to rule out, but it can be, like Tony said, most of this stuff can be done through the history on the televisit.
Yeah. And then, in this diagram, I'm showing you that patients can have combined causes, whether it could be venous and lymphatic, or it could be, somebody that has CHF and venous. And the question is, when you have more than one underlying cause, making sure you have patient expectations set appropriately, especially with interventions for leg swelling.
I think that's critically important because you mentioned that before.
Yeah.
The idea about swelling, and the patients who are not happy if they have an intervention on their superficial veins and their swelling remains. That's got to manage expectations.
And Frank's a perfect example. I mean, you put him in some compression and you see some improvement in them. Now, if this patient had a saphenous vein reflux on one side and with bilateral symptoms, I mean, I've seen more than one occasion undergoing intervention with no improvement.
Yeah.
What's your typical algorithm usually for these patients? Let's say somebody comes in with bilateral swelling, and you're not convinced, even if they have some venous disease, that that's the underlying cause of them.
In terms of treatment, or
yeah, treatment.
I mean, I do tend to lean more towards, obviously conservative in the beginning, compression stockings, exercise, weight loss as much as possible, managing the skin changes. I tend to really wait on interventions on the superficial veins, especially if the main symptom is swelling. I find that, as you mentioned, those folks don't necessarily get better, especially if there's a real significant component of deep venous reflux.
Mm-hmm.
And they're really not going to get better. After they've been compliant with those treatments, I may then, will often move towards a flexi touch to get them to a point where they'll empty out their legs more and have even less symptoms.
And usually what's the time period that you wait with compression before you move on to IPC, let's say? Yeah,
like 6 or 8 weeks, sometimes 12 weeks. I want to make sure that they're compliant, because they really do have to have, commitment to the process. Now, granted, and we've all seen this, there are a number of these patients that are so swollen, have such erythema and cellulitis, inflammation from the fluid, that compression stockings are more problematic and they don't provide any benefit. So those patients, I tend to actively wrap them and try to actively drain them and see them actually on a weekly basis, if not more.
So if I tend to find that even patients that are non-compliant with compression stockings, they're more likely to be compliant with an IPC device.
Yeah.
Especially when their legs are big, like you mentioned, just because it's so difficult for them to get compression on board. All right, let's see here. Let's see, we got a couple of questions here. Do you consider complete decongestive therapy for your patients before compression stockings?
Well, that's part of it. If they have those symptoms that are really severe with the erythema and cellulitis, then some form of decongestive therapy, I think, will help to get them ready to be able to tolerate stockings. That's what my experience has been.
Yeah, I mean, we'll wrap them, like you said, not compression stockings per se, but we'll wrap them with bandages,
Yeah.
3-layer bandages, and try to get them into some type of decongestive therapy. Unfortunately, I don't know how it is in the city, but on Long Island, usually there's about a 2 to 3 month wait period for somebody to get into an appointment for that. So
It is hard to do. I usually set up an appointment after I get folks on the stockings, usually see them within 4 weeks. And I guess that would be at the point in time where if they're able to be compliant for 4 weeks on either wrapping or stockings, then we'll refer them for FlexiTouch. And that usually is enough, to sort of demonstrate their compliance and their response to therapy.
okay. All right. I'm going to stop sharing the slides here. So, okay. So we can get some of these questions answered. Again, whoever has any questions at the bottom of your screen, there's a QA box that you can type them in. Try not to put them in the chat box just because I'm just looking at the QA. So are telehealth visits solely based on time, or can you also bill by E&M coding?
Yeah, I mean, if it's a complex, like Tony said, a complex medical decision making, you can do it the normal way. And then if you have enough elements, the problem with that is it's hard to get the physical exam elements in there.
Yeah.
But you can, with the complexity of decision making, that can get you to the level 2, 3, which is often what you do for your office visits.
Yeah, I mean, you're right. The physical, I mean, the only limitation I actually do see, well, 2 limitations, the fact that you can't do a good physical exam. But for the most part, for swelling, I mean, if you can get a visual inspection and you can ask the patient to, just put some pressure over the tibia just to see if there is pitting edema. You can at least look at capillary refill, have them check that to see the baseline circulation wise. And for the most part, other than getting imaging, you can get most of that information. Are you seeing an increased incidence of thrombotic events during the COVID crisis? I think, there's definitely an increase in thrombotic complications in patients. And anything from DVTs to acute strokes to, we've had mesenteric ischemia, we've had lower extremity acute ischemia, we've had limbs of endografts going down, pretty extensive coronary sinus thrombosis, you name it. So there's definitely an increased thrombotic event rate in these patients. And actually the American Venous Forum, on their website, we've put together recommendations or suggestions based on the current literature on how to manage these patients, at least in the inpatient setting when they come in as far as the anticoagulation. There's a pretty wide range of therapies, anything from full anticoagulation on anybody that gets admitted, I've seen, to prophylaxis on everybody with Lovenox 30 BID, to increasing Lovenox prophylactic dose to doubling the dose to like 60 BID. So there's definitely a range of thrombotic complications and potential algorithms for treating these patients. Anything to add, Nick?
My COVID experience in the last month has been largely in the critical care setting. So almost all the patients I deal with are intubated and pressors and critically ill. And they do, without a doubt, and their D-dimers are quite high. And everyone gets prophylaxis that's in the ICU. But then there are a significant number and more now that are getting systemic anticoagulation.
Yeah, and there's actually some data coming out, both from China and Italy and from the US, that the more aggressive you are with anticoagulation, you do see a reduction in the D-dimer, as well as better outcomes as far as mortality. But they really, especially the ones that have 60, 70, 80,000 D-dimer levels. What guidelines would you recommend lymphedema therapists follow after an acute blood clot? How soon can you start therapy?
I think people have their own approaches to this. And I may be way off, but I kind of feel like after 3 weeks or so, things are pretty mature and adherent, and you can start with some gentle therapy. I go with compression stockings pretty early. I don't worry about that at all. But for more aggressive therapy, I wait a few weeks.
Yeah, actually, we're very aggressive. Sometimes, as long as I think personally, somebody ambulating, if they can walk, the pressure that you have in your calf muscle pump is over 90 millimeters of mercury. I mean, there's really none of the devices out there would come anywhere close to exerting that type of pressure. So as long as they're anticoagulated and they're up and walking, there's really, I don't think any strong reason you can't.
Yeah, that's a good point.
All right. How is Dr. M getting the FlexiTouch approved for a 83-year-old patient? Which insurance does he have?
Oh, it's interesting.
He has the Major League Baseball, right?
Yeah.
Oh, that's right.
He has Medicare with a supplementary, and actually, I think the first time around he was able to get a FlexiTouch because of his supplementary and because of the way we documented his very good adherence to therapy. But sometimes we do with straight Medicare go with a basic pump, and then if they hang in there and we document what they've done and their continued symptoms, then we've had very good success getting them upgraded. We just got to stay the course and hang in there with them.
How do you prescribe compression stockings if you can't palpate their pulses and rule out arterial disease?
Well, to your point before about the amount of compression that's involved, I think, except in the very most severe cases of arterial disease, compression stockings are safe. And we do non-invasive studies in the office, make sure the ABI is good. Sometimes I'll just put the Doppler probe on there and make sure it's a biphasic or triphasic signal, and I'll do my own ABI, and that's usually enough for me.
Yeah, I think the question was more on, in the COVID area, if you're just doing a televisit.
Oh, I see. I'm sorry. Yeah, that's a good question. I'll ask them about symptoms, claudication, rest pain. I think in the absence of things like rest pain or wounds that are obviously arterial, it's okay to give them compression stockings.
Yeah, I mean, I wouldn't go like super high if I'm not seeing them.
Yeah.
But I think if they have, you can at least assess their capillary refill. If they have burst capillary refill, I think you're pretty safe.
That's a really good question, though.
Yeah.
Without the ability to palpate. I think soon we're going to have Doppler probes on our iPhones. We're getting there.
Well,
Then people have to learn how to use them, which is not that easy.
There's actually something very close to that that's actually coming out. It's basically it sticks onto over the blood vessel, and you can actually measure flow rates, flow volume through a vessel. So, seeing any insurance challenges for prescribing FlexiTouch with telehealth visits if you're not seeing the patient in the office? I don't know. I mean, I have no experience with that yet. Have you seen any problems with it?
We're just new to it, so I think that will be something that we'll answer soon. But I think I don't see that there would be a problem because we basically supply the same amount of information. I think one of the issues that I've learned about this, that CMS is very eager to promote telehealth right now. They're being they're giving a lot of leeway, and they really are focusing on not having people come to the office. So I think if the documentation is there, it shouldn't be any problem, any different than an office visit.
Yeah, I think if who popped this question, if you ask your local rep, I'm sure they can get you that information. in your experience, can a patient have both primary lymphedema and secondary? Does that change your treatment? I think briefly the answer, yes. I guess the question then is if they have both, I mean, somebody with like venous disease and primary lymphedema. My only concern in that type of patient for treatment, if you're going to do any invasive treatment, is sometimes you may make their primary lymphedema worse, especially with ablation techniques or any type of surgical procedure in the leg. So I usually am very weary to treat these patients, and from a venous perspective, unless they have, you know, their venous component, I think, is significantly more predominant over their primary lymphedema. If they have post-thrombotic disease, you know, and they need an iliac stent, or, you know, if they have like a 12-millimeter saphenous and they don't have the very typical signs of primary lymphedema in their foot, it's mostly swelling of the leg, then I would be a little bit more lenient on that. What is your imaging choice to evaluate patent IVC and iliac veins? MRV, ultrasound?
I always go with ultrasound first, and the person makes the point about body habitus. Yeah, I think in most cases you can get a good study.
Mm-hmm.
But I like CT venogram too, if that doesn't work.
Yeah, I agree. I mean, our go-to is, again, ultrasound. Again, our center is very comfortable with that. But if you're not comfortable with the findings of your ultrasound, at least in the beginning, until your lab gets comfortable, you can do both and correlate it. And then at some point, you'll get comfortable enough that you really don't see CT adding much more. Are you scheduling new patients for telehealth visits or only follow-ups?
You can do both. And there was a regulation that for new patients, you had to have a license in the state where they lived, but that's also foregone during the COVID crisis. So we're doing both. And do you think an initiation of conservative care after an ultrasound will allow for scheduling vein procedures after 3 months? I think so. I think you could do that after a telehealth visit.
Well, the problem is if you don't have an ultrasound finding, you know, you don't know what the hell you're going to be
He does
treating.
mention if they have an ultrasound. Yeah.
Without
An ultrasound. No, I'm sorry. I thought it was with an ultrasound. No.
no, but at least you can get them on a conservative trial of compression, and then have them come back if they're not using, you know, compression stockings. Because unfortunately, most insurances still have that requirement. What are your expectations to use telehealth for lymphedema following the pandemic? I think we kind of answered that from earlier.
I mean, it may be a perfect place for it because a lot of these folks are not as mobile to get to the office, and you know, you can do a lot over the televisit.
Right. The question now is how to manage the post-hospitalized patient recovering from COVID or those that stayed home and recovered. Management of thrombotic risk and those with symptomatic CVI. Should we avoid ablation treatments in the recovering COVID patient? All right, so there's a few questions there. As far as how to manage post-hospitalized patient recovering from COVID, you know, if that patient needs to come in for a visit, we prefer to do a televisit on them. If they need to come in for a visit, we'll schedule them usually 2 weeks after their discharge and at least 72 hours symptom-free before bringing them in the office and exposing everybody. We're still kind of treating everybody that comes in as presumptive positive COVID because, as we know, most of the patients are asymptomatic. But if they definitely, you know, were positive, that's kind of the protocol we have. When they get discharged from institution, our place at least, we're sending them home, especially the ones that had really high D-dimers, we're sending them home with a month supply of prophylactic Lovenox or Xarelto or Eliquis, just because we've actually seen probably around 5 patients come back with a PE. So we're, you know, and I think that we're treating them basically like a pelvic operation or a hip replacement where they go home with a month of prophylaxis. As far as avoiding ablation, I think that's the right thing to do. I wouldn't be treating, not only because of the increased thrombotic risk, but also exposing yourself and the staff.
Yeah.
What level of compression do you prescribe for stockings in patients with DVT? Nick?
I'm usually 20 to 30 is my go-to.
Yeah. I mean, for the most part, that's when the patients would be most compliant. You know, patients with ulcers and lymphedema usually will go a little bit higher as long as they don't have a weird body habitus that they're not going to be able to tolerate it. How do you rule out PAD prior to recommending compression? We kind of answered that a little bit. I mean, unfortunately, again, if you're just doing a televisit and you don't have an ABI, it's a little bit difficult. I would go with a lower compression, you know, either 15 or 20 or 20 to 30, as long as they have no other risk factors or signs and, you know, symptoms of peripheral vascular disease. What compression garment do you recommend? Do you have a certain brand of anything?
I'm not particular in terms of the brands. I find a lot of people in the days of Amazon go on their own and get. And I find that if it's something that they're comfortable with and they seem to be improving and they're compliant with it, then I go with it. But you know, the Jobst and the others that are truly sequentially graded, those are probably the better ones.
Yeah, I mean, we don't really have a preference. And even if we did, patients usually go and get what, you know, they can find. Do you maintain that PAD is a contraindication to superficial therapy? For the most part, no. You know, unless they have advanced disease, you know, like rest pain or tissue loss. And there's a small subgroup of patients with CVI that have both or mixed disease, arterial and venous.
I have a patient like this who came to me with bad Achilles gangrenous ulcer and really bad tibial disease. Could not treat him endovascular, and before he came to me, he had a saphenous ablation, so he didn't have a conduit left for his bypass. Fortunately, we've been able to save the leg, but if there's a significant amount of tissue loss that's not clearly venous, then I would be hesitant.
With the number of ablations being done these days, I mean, the reality is, if you look at at least the literature of saving the saphenous vein for CABG, it basically, you know, most of those patients never really need that saphenous vein. And there is some data or some literature that shows that patients with venous disease, which is felt to be a collagen abnormality, have some protective effect of the effect in developing coronary or peripheral arterial disease. But there are a small group of patients that do have both. Have you found any capabilities to complete insufficiency testing outside of the office?
You see that one? Like Tony said, you can bring them to the lab if you screen them appropriately and they seem to have an indication for getting the study. We have an office on 51st Street, which is away from the hospital, which, although you can never guarantee that the place is COVID negative, but we have a lab there too, which they can sometimes use.
The question popped up again, would you not treat venous disease in someone with primary lymphedema? Again, the problem I have is if the only symptom that they're having is swelling and edema, I usually encourage them not to treat their venous problem. Unless their venous disease, to me, I feel like is overwhelming their lymphatic disease, their primary lymphatic disease. Now then again, you know, like we said, patients with venous disease is the number one cause of secondary lymphedema. So if it's secondary lymphedema, then treating their venous disease may help their swelling. The problem is if they've had long-standing swelling and long-standing CVI, their lymphatic system may have been damaged from overwhelming the system over the years. And even if you treat them, you may not see improvement. But for primary lymphedema, where their only symptom is swelling, they usually don't encourage patients to. I don't personally would treat them, but just because you may make their primary lymphedema worse. And that's just from personal experience. I don't think there's any literature out there on that. Have you been utilizing prescribing NAV products such as the Flexi or at-home management after training? Yeah.
Yeah.
Okay, this is an interesting. What are your thoughts on the optimal way to reopen your vein practice for elective patients? You want to chip in a little bit?
I think that's a really good question, and we're grappling with that in terms of all of our practices. I think the rate limiting factor may be the patients themselves, because there's going to be some trepidation to come back. But I would recommend, an aggressive early outreach to referring doctors and to established patients when there's an idea that things are going to be opening up. You may want to consider, for the foreseeable future, we should be having our staff screen the patients on the phone for symptoms. And in medical office buildings, there should probably be a temperature station at the entryway for folks that are coming in to screen people for fevers.
Yeah, I mean, that's what we're doing. We're basically make sure they have no symptoms when they call, temperature check, and hopefully we'll have the rapid antibody or the antibody test soon that we can test these patients, especially if you're doing in-office procedures, and especially if you're doing sedation on these patients. But I think the best way to practice with these is assume everybody's positive with personal protective equipment. Otherwise, you'll never be able to find all the patients unless we get to a point that everybody gets tested everywhere, whether it's at a restaurant or in the doctor's office. But as far as reopening your vein practice, for some of the things I've been thinking is, marketing perspective, when to start that. If you do screenings, when to start that. Obviously, you probably have a group of patients that were canceled abruptly, so you have a pool of patients that already have approved or being approved that you can start scheduling. And then the other thing we're doing is we're basically trying to figure out how we're going to start seeing patients and not have a waiting room of 30 people sitting there. And that involves stretching your hours of operation. That involves opening weekends, because you're going to have to accommodate the same volume, but only limit it now to maybe, I used to see patients every 15 minutes. I'm going to have to start seeing patients maybe every 30 minutes or even longer. Our vascular lab is terrified of having, a ton of patients going in and out. We're actually looking to change our vascular lab way around and having an ultrasound machine in the exam room where the patient is, so they're not moving in and out of those rooms, and even creating a negative pressure in those rooms to help with airflow, and filtration. So there's a lot of things you can do. Obviously, it involves cost and planning, and this is the time to start planning those things. Because unfortunately, at least for the next year, we're kind of stuck with this.
And I think the patients there's going to be a lot of hesitation,
Yep.
a lot of anxiety, and we're going to have to manage that.
But I think, and this is where you do your marketing, where you're, if a patient walks in and sees a waiting room of 30 people or a waiting room of 2 people, it's going to be, or 5 people, they're going to have a different level of comfort. So if you're able to accommodate and make them feel better, I think you'll be easier to do this. We kind of touched that already. How are you measuring patients? So we're not, as far as measuring them for compression stockings. We just have them go to whatever surgical supply store and get them measured. Usually they measure them. We don't even measure them in our office beforehand. We just have them even in the past. Are your telehealth visits up, down, equal to pre-pandemic? Oh, we never even did televisits before. How about you?
Yeah, we're up tremendously. We just switched to Epic, like I said, so it was perfect timing, but we're way up.
When in the patient's treatment protocol, I think, do you prescribe IPC? I think Nick kind of answered that. My only difference is, you know, I would go a little bit, I usually, if they really need IPC, I tend to be a little bit earlier, just because, like I said, it takes forever for these patients to get into any MLD type of therapy. And I find them to be a lot more compliant with IPC than compression. Obviously, they need both, and I try to reinforce that to them. But they definitely are more compliant with the pump versus compression stockings. Have you had a patient problems with a patient not being able to participate in telehealth due to poor comprehension? Nick, have you?
Usually that's an age or a language issue, and when that happens, their family members are way out. They're right on top of it. In my experience, they've been there. Oftentimes it's a grandchild because everyone's sequestered at home. So we have interpretation and things like that. So we've been fortunate so far.
Yeah, and I think, and I was actually surprised also because I thought there would be an issue with technology, but if there's somebody from the family, I mean, the family member was going to drive them usually to the visit, so now all they have to do is go over to their house if they don't live together. And interestingly, if you try to communicate through audio and video, and for whatever reason you cannot, or the patient cannot get connected, and the intent was to do a televisit, and you have to call them only, you can actually still bill it as a televisit, as long as the intent was there, and, you know, if there was a problem with connecting. You gonna take the next one, Nick?
Was that the one on obesity?
Yeah.
Well, how do you factor in obesity, sleep apnea, pulmonary hypertension as etiology of CVI and chronic leg swelling in terms of workup and management? It's just like when we showed on that slide there, all of those factors can play into what I described as chronic venous hypertension, which then leads to valve failure. So the thing that's important is they kind of lead down to the same final common pathway. So they're always considered and reviewed in the diagnosis because it often helps patients to understand why they're having this problem. But I end up treating them all in a very similar way.
All right, so how do you know when a patient has primary lymphedema along with secondary lymphedema due to CVI? I think that's pretty much just history. I mean, the primary lymphedema, obviously, they've probably had for a while, and if it at some point progresses or gets worse, I mean, it could be the natural history of it, but it also could be underlying contributing CVI. And I think, again, the thing here is patient expectation. And if their main issue is just the swelling, you know, I explained to them there's treating you for that alone may make your primary lymphedema worse. For the most part, I've never had somebody actually force me to treat them.
Yeah.
So, and I think this is the last question, unless anything else pops up. What percentage of your patients wear stockings, considering places with hot weather?
Well, hot weather is always a tough one, and the summertime is always a tough one as well. And a lot of the folks, when we get them into FlexiTouch early, and if they're very compliant, they'll find that they can take a significant amount of stocking holidays and get through their days without having to wear them. But, you know, you sort of biased when they actually come back to you and you don't lose them to follow up. I think the compliance goes up pretty high.
All right. So,
sure.
Any closing remarks, Nick?
No, I think this is like we're all of us, a couple hundred of us on this call, dealing with a curveball that, although the potential was there, I don't know that any of us knew the extent to which we would be back on our heels. And I think telehealth is providing a really good option for maintaining connection with your patients and providing care. And I think it will be here to stay afterwards for selected patients. And I think it's going to be quite a while before a lot of people are fully comfortable coming in. So I encourage people to engage and try to exploit it as much as you can in terms of getting a lot of information about the patients and making a bond.
Yeah, I think, I mean, like I was painting a pretty grim picture earlier about, not being able to see the volume of patients, but hopefully telemedicine will allow you to wean out the ones that don't need to come to the office.
Yeah.
And basically, even though, let's say you were seeing, 30 patients a day, you can now see maybe 15 because of trying to make everything kosher. At least, if you can get 10 or 15 of those on telemedicine, they'll just try to catch up that way. I think we have a couple more. So, I have a patient with primary lymphedema and severe CVI. What do you recommend? Again, this is a tough situation. But if they have severe CVI, especially if it's deep pathology, I wouldn't have a problem treating, like an iliac obstruction. Superficial, I would probably offer them treatment if it's really bad. And what is really bad? Yeah, that's a tough one always. But, if their saphenous is like 8, 10, 12 millimeters, and then in this situation, I may go with a non-thermal ablation over a thermal device, just because you may get a little bit less of an inflammatory reaction or injury to the surrounding lymphatics.
Mm-hmm.
And then one question on, if patient has multiple varicosity issues, how many times can you do Varithena on the same patient? Nick, do you have any experience with Varithena?
I don't use it, so I couldn't answer that one.
Right. I mean, we use it. It's approved for both the saphenous vein and varicosities. The reimbursement, some people have been playing around with it a little bit. Really, the reimbursement is for the saphenous vein. If you're bringing them back multiple times for varicosities, I don't use the same code. So I usually use just ultrasound-guided sclerotherapy for the varicosities if they need multiple treatments. All right, I think we're pretty much done. I thank everybody for attending this. I mean, we had a great turnout, a lot of great questions. And I want to thank Tactile for putting this together. And look out for more events to come. Thanks, everybody.
Thank you.
Good night.